Hey, welcome to Coffee with Tim. My name is Tim Hague Sr. I'm a professional speaker, author. I have Parkinson's and I'm a PD Avenger. Welcome to Coffee with Tim, a conversation of life and Parkinson's disease. I thought maybe my dog was coming in. Forgive me. Most of you will have met Bella by this point, so if she does wander in, that's fine. I want to remind you that Coffee with Tim this month is brought to you by the Parade for Parkinson's, a 5th-year birthday celebration of U-Turn Parkinson's. Wellness Center here in Winnipeg, Manitoba. Visit uturnpd.org and empower our pursuit of wellness. Well, it's been quite the week, guys. I am back to a COVID beard for no other reason than the fact that I've not been out of bed for 3 days. We'll talk about that in a bit. I've got with me Dr. Sonia Mather again today. It is Dr. Mather and Nurse Tim. Only one of us can say they're still a doctor. The other one's no longer a nurse. It's interesting. Good morning, Sonia.
Good morning.
It's intriguing to me that nurses have to say that we're retired at a certain point.
Oh, I count myself as retired. You know, just before we get started, since we're putting our healthcare professional hats on, so to speak, I really want to just give a shout out to all the frontline health workers that are covering this. I mean, we're at the worst point in this pandemic, and the fact that you and I both know what that must be like, and the decisions they have to make and the situations they have to face is just unfathomable. And I, express sincere gratitude for everything that they're doing and admiration.
Absolutely. Thank you for saying that. I would echo that 100%. So many of my nurse colleagues I'm still in touch with over social media in various ways. Mm-hmm. And when I look at the work that they're doing, the time that they're putting in, the effort that they put in, it's absolutely amazing. I'm not jealous of their position right now.
No, but I sometimes feel bad that, Parkinson's disease has sort of taken my ability to help out in that way, like hands-on. Yeah. I sometimes feel bad about that, but.
For real. I mean, I thought about here when the call went out for just retired nurses to come help give immunizations. Mm-hmm. Well, I could surely do that, couldn't I?
Yeah, I know.
Can you imagine poor patients sitting there watching me come at them with a needle? It's not gonna work.
Oh, been there.
But it is frustrating that something so small you can't do. But,
yeah.
I certainly appreciate all my nurse colleagues, all the physicians, all of the folks in healthcare, all the people that don't get mentioned every day, the respiratory therapists, the PTs, everyone who still go to work every day, do the hard job, to keep us safe, to keep us all working and doing well.
Absolutely.
Well, thank you for that. Well, let's talk about this COVID-19 vaccine. I got blindsided this week, big time. Like I knew that lots of folks were having, headache, fever, chills, muscle pain, joint pain, variety of things with this, but I didn't really pay attention to that, right? How big a deal could it really be?
Right.
Tuesday noon, I go to my pharmacy, get my AstraZeneca. And Wednesday morning, I woke up, Sonia. It was like a herd of elephants had kicked me in the left shoulder and across my brain. Like, what is that about?
Yeah, it's funny how you had that reaction. I had the Pfizer vaccine, or any vaccine, it doesn't matter, but I had the Pfizer one a few weeks ago, and I just had a bit of a sore arm, and that was it. So everyone's going to react differently to it, as you can well imagine.
Well, I figured this week coming into Coffee with Tim, I'm going to share the warning. I don't want to dissuade anyone from getting your vaccine. For heaven's sakes, go get your vaccine.
Yes, absolutely.
But I don't want you to be surprised if it isn't necessarily fun the next couple of days afterwards.
Yeah, and there's no way to predict who's going to react and who's not going to react. Unless if you've had similar reactions prior, then maybe it puts you at an increased risk for that. But it's hard to tell. But like we talked about before, it's much better than getting COVID.
Oh, yeah. If this was even a small sampling of COVID, I do not want COVID.
No.
Like, this was intense. The headache I had must have been close to a migraine. I can't say that I've ever had a migraine. Lights needed to be out. Any kind of screen time was just not good.
Right.
It was rough. My joints just ached. I had a hard time turning over in bed because I couldn't push down with my hands because my wrist would hurt. Like, I haven't felt this sick in years.
That's terrible. Well, I'm glad you're
Am I just a wimp, Sonia, or was this?
No. Everyone reacts differently. I don't know what it'll be after my second dose, so I can't say anything.
Yeah, that's the other thing now. Do I want to go for my second dose? Oh my God. No, I will be there for my second dose.
Yeah, for sure.
Absolutely.
For sure.
Well, let's talk about what we wanted to talk about today. I have been asked a few times about various medication regarding Parkinson's, of course. And folks had a variety of questions, things like, when should I start my medication? Should I start my medication right away? Should I start it later? Should I start with dopamine replacement? Should I start with something else? There's all kinds of conversations around this out there in the world. Where would you start this conversation?
Where I would start this conversation, Tim, is ask the patient what their quality of life is like right now with what they're doing. If they're pre-medication, are they able to do the things they want to do, achieve the goals they want to achieve? And that can just be simple things like getting up and getting dressed by yourself and, performing your work occupational duties on your own, taking care of your family, that sort of thing. Are you experiencing the quality of life that you are happy with? If you're happy with it, then fine. Don't consider anything else. But if you're unhappy with it because the tremor or the motor symptoms are really bothering you and interfering with your ability to function, or your life experience is getting ruined because of them, then it's time to think about adding on medication.
And what if I'm not quite sure? What if I'm a little uncomfortable with my tremor or whatever my symptom is, and I think there might be options out there that would make life better? How do I think about that then?
Again, everyone's going to have a different threshold of how bad things have to get before they move on to the next stage. But what I would suggest is don't be afraid to move on to the next stage if you have to. There was a time, as you well know, Tim, that neurologists even would say, hold off on taking levodopa, which is, again, the gold standard treatment for Parkinson's disease. Hold off on it because the fact is that it's going to lose its effectiveness. Your body's going to get used to it. You're going to accelerate your disease faster. We know that's not true anymore. That you don't have to fear those issues anymore. So that's why I would say don't fear the medication if you have to go on to something like that.
Yeah, because I delayed my medication start when I was first diagnosed for 3 years. And I'm pretty convinced, looking back, I might be wrong. This is hindsight, right? Trying to look backwards, but I'm pretty convinced that had I started my meds sooner, at least by a year, 2 years, I probably would have stayed nursing for some time to come. Because I think, and again, this is just me looking back, trying to second guess things. I think it would have allowed me to settle into my diagnosis sooner. It would have allowed me to have dealt with my symptoms sooner. Probably would have allowed me to find a better equilibrium between my symptoms and my work and what I had. Because by the time I had to quit work, my symptoms were so bad that I simply couldn't deal with it.
Right.
So it might be a little bit of wishful thinking to look back and think that I could have held on longer. But I do really wonder what it would have been like if I'd started my meds sooner. Yeah,
it's hard to say. Mine was a little different in that I went through 3 pregnancies and breastfeeding and little ones around the house. So, my medication history and when I began my medication is kind of a little bit messed up in that way. But I remember reaching a point where I was in my office and I was having to time everything so meticulously so that I was seeing my immunizations first thing in the morning when I wasn't as fatigued and my tremor wasn't as bad, or I was having to kind of contort my body in such a way that I could control the tremor when I was seeing patients. I remember calling my movement disorder specialist at that point and saying, I got to get on something. I'm at the point now where it's really affecting my daily living and I have to do something about it.
Yeah. And that's pretty much what pushed me across the line. I was at a point where the doc was I was complaining to the doc, well, I can't do this, I can't do this, I can't do this, I can't manage everything I'm doing. He started saying, well, you're going to have to either start taking some meds or stop something. I wasn't prepared to stop anything. I wasn't doing all the things I was doing, so I said, well, then it must be time to start meds.
Right.
And as soon as I started my meds, I could suddenly manage my life again.
Yeah.
And that's what was shocking to me. So
it is. When you respond to levodopa, it's quite the shock in terms of how you feel. I agree.
Now, levodopa is called the gold standard.
Mhm.
Tell us why a medication is called the gold standard.
The gold standard is the gold standard medication is what every other drug is kind of compared to that comes out to treat the same condition. So all the other drugs that have come out would be compared to what the best medical treatment is that we have right now, and it is levodopa. Because we're basically replacing what we've lost in terms of motor symptoms, at least.
And levodopa is a very natural replacement, am I correct? That what we lose in our substantia nigra, we're taking that and replacing it with dopamine.
Exactly.
We're taking and putting it back.
Exactly. So levodopa we take in, it gets absorbed through our intestine, then it goes across the blood-brain barrier and replaces it in the brain. It gets converted to dopamine and basically replaces a supply that we've lost.
Okay, so it's not something foreign that we're putting into our bodies. It's not something new and weird that we're putting into our bodies. It's in a very natural kind of replacement.
I guess in that way, yeah. In that way, we're not trying to trick the body into thinking that we're putting something else in there. We're sort of replacing what it's lost.
Okay. So then, why would we start with any other drug other than our gold standard? If we have a gold standard and that's the one that we know works best for the most people, and I guess that's important, that it works the best for the most highest number of people, why would we start with some other drug beside that?
Well, there's a couple of things. One, it's the comfort level and the experience of your neurologist or movement disorder specialist. Some specialists like other drugs to start with, just as a habit of practice. Others will find that, I mean, some people won't respond to levodopa, and that's a whole different situation. Some people find the side effects of levodopa can be quite debilitating. Like some people have really a lot of nausea with it, or lightheadedness, or some can even have hallucinations and that sort of thing. So that might be a reason if there's a serious side effect to the levodopa. But again, I think it's that old school, and some patients don't want to take levodopa. They go to their neurologist and say, I don't want levodopa. And that's, again, a miseducation or miscommunication issue with what people feared about levodopa before. But personally, I mean, I think it's a good fit for most people. Thank
you. And that's exactly what I was looking for there. I've heard lots and lots of people not want to start their levodopa right away, especially younger people, those with young onset, because they're afraid of the dyskinesia starting sooner than later and having trouble with it.
Yeah, and that is one of the reasons people won't start. You're right.
Yeah. And I just really want to encourage folks to make sure that they're weighing all the potential benefits and all the pros and cons.
Right.
Because let's talk about some of the other drugs, the agonists. Well, let's talk about, first of all, what other options do we have in terms of medications? We've got agonists. We've got
MAOB inhibitors.
Okay.
We have a group called COMT inhibitors. And
all those things do basically the same thing?
Yeah, I mean, the MAOB inhibitors and the COMT inhibitors basically help prevent the dopamine or the levodopa from being degraded or break the dopamine down. They kind of help with blocking that breakdown of dopamine in the brain. So MAOB inhibitors, the COMT inhibitors do that. Dopamine agonists don't change into dopamine, but they mimic the effects of dopamine on your brain. So they bind with the receptors that dopamine would normally bind with, kind of tricking the brain into thinking that there's dopamine there.
So we basically have two other options. Those that mimic, pretend to be dopamine, those that keep dopamine from being broken down.
Right. And we also have amantadine, which I don't think we really, or I don't clearly know how it works, but it's certainly helpful in early stages of Parkinson's as even a primary treatment. And in later stages, it can be helpful for helping with dyskinesias.
And what kind of side effects come with some of these meds?
Well, anything, as you know, even aspirin has side effects, but I think one thing that we have to be aware of with the dopamine agonists, other than, some of the sleepiness or nausea or constipation that can come with it are the other side effects that are sort of what are they? I'm having a parking moment.
Oh, all the yeah, there we go. My mind just the gambling.
Yes, yeah.
The addictive.
Yeah, the addictive sort of behaviors or compulsive sort of behaviors that you can get.
Behaviors.
Yeah, the impulsive compulsive disorder kind of behaviors that you can get, like the hypersexuality, the overeating, the gambling, and that's a real issue.
So I just want to encourage folks to realize that we don't have many options when it comes to treating this disease, Parkinson's. 2, everything that we take has some sort of potential negative side effect to it. And that's so each individual got to make our own decisions as best we can and being as educated as we can. But to really weigh out, do you take a gold standard med versus another med, and why? What are your potential ups and pros and cons on both sides? Because I've heard some just outright dismiss certain meds for what doesn't sound to be like a lot of good reason. It worries me that they're putting themselves potentially at harm for other more difficult side effects.
Yeah.
Which would be unfortunate, right? Which would be very difficult. So I want to encourage folks to make sure that they're really weighing out the pros and cons, that you're really getting good information.
Exactly. Because unlike other health conditions, there's nothing we can say in Parkinson's disease that you must take this medication because it'll modify the effect or the trajectory of your disease. There's nothing like that. So what we're doing is we're treating your symptoms so that we can optimize your quality of life. So that's a very personal decision. And then that's why you're right. You have to weigh the pros and cons of each of the options that are available to you and decide on what you want to do based on your life circumstances and your feeling on the matter. Which
can be a little more difficult sometimes, right? Because when you walk into your doctor's office and your doctor says, "What do you want to do?"
Yes.
What do you mean, what do I want to do?
Yes, I know.
We sometimes feel like we're being asked if we want to take chemo or not.
Yeah. Yeah, no, I know.
But that your point is well taken, that this isn't a decision that has to happen. You can start a Parkinson's medication and you can stop a Parkinson's medication and not necessarily make a significant difference in your quality of life.
Exactly. And just to, preface, this covers what we've said and what we're going to say is that at no time should you start or stop a medication on your own. It should always be done under medical supervision because there are some Parkinson's medications like MAOB inhibitors, for instance, that if you stop abruptly can really be dangerous to your health. So you have to be careful. And there's other things, if you have other illnesses or medications that you're taking that you really need to be aware of or have someone with medical knowledge to manage that.
I know as smart as we are and as good looking as we are, you can take anything that we say as gospel truth, right? Don't do it. Just don't do it.
Yeah.
Oh, and don't make any decision without the help of your physician, your medical team.
Yeah, absolutely.
You don't go off the advice of just some guy you heard, even if it's Tim Sr. But he won the Amazing Race Canada, doesn't he know? He knows he's forgotten more than most of what he ever knew.
Oh.
Well, what other options do we have in treating Parkinson's, Sonia? We've got our agonists, we've got our various meds we talked about.
Yeah, there's different delivery systems. Like in the US, you can get inhaled dopamine as a rescue medication. There's also subcutaneous morphine, apomorphine, and now available, I think, or soon to be available in Canada, under the tongue formulation of apomorphine, which is a rescue medication, which you would take at the time you are off or having some freezing issues. There's other ways to deliver levocarbidopa in the form of duopa, which is where they put a feeding tube into your intestine and deliver it that way so that you get more, you don't get the ups and downs as much. That kind of smooths the delivery system and the level of dopamine. And then we get into more of the other stuff like surgical management, such as DBS. Focused ultrasound is a non-invasive form as well of ablation therapy. And then there's stuff coming down the pipeline as well, which will be interesting in terms of stem cell treatment and gene therapy and that sort of thing.
Okay, we're going to save that thought for another day.
Yeah.
That comment always entices me and irritates me. I've had Parkinson's just long enough now 10 years to have caught the tail end of the discussion of we're going to cure Parkinson's in 15 to 20 years. And of course that didn't happen. And now there's talk of all this stuff in the pipeline. So I'm excited about that. And I'm extremely hesitant of that comment all the time.
Understandably so.
I'm just a wee bit jaded.
It is exciting though. There are some good stuff coming down.
Well, I'm hopeful. Well, I'm confident. I should put it this way. I am confident in humanity.
Yeah.
If we can put a dune buggy on Mars with a little helicopter on board that can beam movies back to Earth, if we can come up with 5-6 different vaccines for COVID in a year, we can do something for Parkinson's.
Absolutely.
What I'm less hopeful of is whether or not we have the will.
Yeah.
And that's the more jaded, older side of me.
It's understandable, for sure. I think my jadedness comes from, I'm not really jaded, but my concern comes from the fact that we really don't know what causes this disease in the first place, and you can't really cure what you don't know. So I think a lot of research has to be directed towards that.
I would agree, but I do remain confident and mostly positive and hopeful that we will do something positive with this in my lifetime.
Yeah, there's a lot of innovative thinking going on, a lot of innovative research that's hopeful.
Which is huge when you consider that it took 143 years before we found that we even understood. No, let's see, it was 143 years before we discovered dopamine. Or levodopa, and it was 143 years before we understood that there was a lack of dopamine in the striatum of the Niagara, substantia nigra. One was we were cutting people's brains open after they were dead to find out what was really going on. The other one was treating it. I'm forgetting which state was which. But it took a long time to get there. But from there, from the 60s to here, we have done leaps and bounds. We have come so far in our understanding of Parkinson's.
Absolutely.
So far that we understand that it's so much more complex than we originally thought it was. But that in and of itself is a massive leap forward.
Yeah.
We've just learned so very much about it. Well, I think we're going to leave it there for today, Sonia. Appreciate having you on again. It is always a pleasure.
My pleasure to be here. Thank you so much.
You're very welcome. So we'll have you back on again sometime and we'll discuss some other topic that folks ask about that you can add your wisdom to. Okay, we'll see you.
Take care.
Well, gang, thanks for tuning in today. It's always great to talk to Dr. Sonia. And hope you have a great weekend. Enjoy. See, the dopamine is just gone here. The whole thinking process is just shot now. But this is what I'm trying to say. Have a great weekend. Give a hug to those you love. Stay on your journey, persevere, because this race, your race, can be won as well. It's been great being with you today. Have a great time.